Okay. All right. So, hello everyone. Thank you for coming. For those that were able to show up, and for those that can't, we are recording this for you guys to view at a later time. Welcome to our next Fuller's ANST lecture series this spring. I have the wrong date on there. I apologize. Um, Real quick announcement. Thinking about joining the Fuller ANST leadership team. Um, Here is the QR code if you're interested. Um, just send us, just answer the quick questions about yourself and why you're interested, and we'll get in contact with you. We are hoping to send out a response to the requests by the end of this week, May 23rd. And today we have Dr. Birath, Dr. Brandon Birath. He is a board certified clinical neuropsychologist who specializes in evaluating criminal defendants with neurocognitive and neurodevelopmental disorders. He earned his PhD from Fuller Graduate School of Psychology and completed his neuropsychology postdoc fellowship at Harbor UCLA Medical Center. He is board certified in clinical neuropsychology by the American Board of Professional Psychology. From 2015 to 2021, he served as the chief of psychology at Olive View UCLA Medical Center, where he currently serves as a co-director of psychology training. He is also appointed as health sciences assistant clinical professor in the David Geffen School of Medicine at UCLA. Since 2017, he has been a member of the neuropsychology section of the Los Angeles County Superior Court expert panel. He also serves as a post-conviction habeas corpus consultant with the Los Angeles County District Attorney's Office and the Federal Public Defender's Office. He maintains a forensic private practice based in Los Angeles. All right, and take it away, Dr. Barath.
Okay, so you're gonna make me a host here where I can
Yes,
share
sir.
my screen. Okay.
Mm, okay.
Should be good now. Okay.
Sorry. Okay, there we go.
Here we go. Okay. Does that look like it's full screen on your end?
Yes.
All right, perfect. Hey everyone, thank you for being here. And for those of you watching later, thank you for joining us afterward. So uh, I have several things to talk about today. One is the first I want to really talk about is the nuts and bolts of my private practice because I got the sense that's where there's a lot of interest. But then there are some topics in neuropsychology and the justice system that we can cover, or at least go over briefly, and then we can just sort of do a casual Q&A. Um, so thank you, Juan, for the invitation. You already read all this stuff. I don't have any financial interests in the presentation. I want us to talk about my private practice as an example of what one can look like when you're a neuropsychologist doing forensic work. And then I want you to understand how neuropsychology can be useful in the criminal adjudication process. And the things we're going to sort of just focus on briefly are competence to stand trial, not guilty by reason of insanity, and mental health diversion, and which is a statute in California. And then we'll just kind of briefly discuss some neurocognitive disorders relevant to criminal defense for mitigation and diversion. So, in case it's not obvious yet, my forensic private practice is criminal in nature. I don't currently do civil work. I have done some in the past. So this talk really does focus more on criminal work. I'll be happy to answer questions about civil work if I can. Um, so let's just start with what happens in my private practice. How does it work? You already know about my background and my training, um, and we can talk about that a little bit more later. But um, obviously I'm trained as a neuropsychologist, not as a forensic psychologist. My postdoc and my board certification are in neuropsychology. Um, so forensic was something I came into after the fact and have trained in and worked in now for about 7 years. Um, so in my practice, it's like I get to admit people when, okay. So in my practice, here's sort of the workflow. All right. So an attorney contacts me. They send me an email or they give me a call and they say, Dr. Birath, I wonder if you could help me out with my client. Um, I, they may know what's going on with the client, or they may not know. They may just think something seems to be wrong with my client. I think they're lower functioning, or they had a TBI or something like that. So then we discuss the case and we discuss what their referral question is, so that I can tell them what I can and cannot answer. And in that process of that dialogue, I kind of help them shape the referral question because a lot of times the attorneys don't even really know what they should be asking me to do. And so we have a conversation about the case. And if we agree that it sounds like something that I can help with, then the attorney will submit an order to the judge, and the judge will sign the order. And then the attorney will send me whatever records they have or whatever they can get regarding the person's substance abuse or mental health or medical treatment. Also, the attorney will provide me with contact information for collateral contacts, usually family members that I can interview about the client. And then we schedule an evaluation, takes place over multiple days. Um, and then once everything's scored up, I give feedback to the attorney because in these cases, the attorney is the client, actually, um, not the person you're testing. And so the feedback goes to the attorney. And normally they want me to write a report answering the referral question that we decided on. And so I will write a draft of the report and send it to them for them to read to see if it answers the question in a way that is useful for them for whatever legal trajectory they're going for and what sort of step in the process they're at. We then, I consider feedback from them. I think, is there something I need to expand on or revise? And then I send them a final version of the report. And usually that's where it stops. Although in some cases, there's always the possibility of testimony or other follow-up. Like they may want me to see the same client again a year or two later. Maybe they pick up a different case, that sort of thing. And I may need to do a reevaluation, or they may some new legal avenue may open up for the client, and they may want me to opine on that. So sometimes these cases stretch out over a period of years before they are kind of closed out and done. So, so that's my practice, and I should pause here just to ask: are there any questions yet about my practice? Because I'm about to jump into some forensic topics, but just in terms of how my practice operates, any questions so far?
I do actually have a question. I'm curious about the connections when the attorneys are reaching out to you. Do you work through the court and people make recommendations based off of how does that work? How do you connect to the attorneys?
Okay. So I should back up a slide here. I think we may have actually jumped over this one. So most of my work comes from the LA County Public Defender's Office, and that is through the LA County Superior Court. So almost 8 years ago now, I got on the LA County Superior Court's panel of expert witnesses. And so the attorneys, there's dozens and there's like tons of experts in all different subject matters um, on this list, and they're approved by a panel of judges to be on this list of experts. And so the attorneys can look at that list and find the neuropsychology section and find people on there that way. Of course, the more time you do this work, people learn who you are, and you also gain um, through word of mouth, people learn who you are, and you get recommended, hopefully, if you do good work. And so that's where most of my work comes from. I also do work with the Federal Public Defender's Office. And so that's not just in LA, that could be in San Diego, it could be in another state. Um, I have done some work with San Bernardino and San Diego County Public Defender's offices. Um, One thing that I also do that's kind of interesting and different is I consult with the district attorney's office. So this is the prosecution side. Um, and also with the federal public defender in habeas matters. And so what that means is habeas corpus matters are when someone has been convicted and sentenced and they're in jail and their case is being reviewed. And essentially they're filing a legal argument saying that they should not have been convicted or they should be sentenced in the way that they were. And so it may be a case where 20 years ago, someone was sentenced to life in prison, but their case is being reviewed, and their attorneys are now asking me to review testing that was done at the time and opinions that were given at the time to see if they really hold water, or if maybe now, in light of some new information that's come out since then, if the opinions at the time maybe weren't as valid as they could be. Okay, any other questions before we move on? So I want to talk about the intersection between neuropsychology and the justice setting. This is uh, not a comprehensive list of the ways in which neuropsychology can get involved. So I've got three things bolded here: competence to stand trial, insanity defense, and mental health diversion, because we're going to talk about those in a little bit more detail. But also susceptibility or false confessions, generally just mitigation. This is probably the most common one. They just want some mitigation for the case. Um, Obviously, the identification of performance invalidity or malingering is useful in this setting. There's another statute in California where you can get regional center diversion. We're going to talk about mental health diversion. Do you guys know what regional center is? The state-funded entity that supports people with developmental disabilities, children and adults. So if someone has intellectual disability, for example, they can get services through regional center. It's wraparound services. It's housing and job training and medical and mental health support. And so a lot of the cases I do, the public defenders are trying to get them accepted into regional center as clients, and they can get diverted out of the criminal justice system for that. So let's talk about competence to stand trial. I think these slides were made for a more in-depth talk on these topics. And so we're not going to get too far out into the weeds on any of these, but essentially competence to stand trial is an evaluation of whether the defendant has a reasonable degree of rational understanding, a factual understanding of the proceedings against him, and whether or not they can work with their attorney. And so the original case was the Dusky case. Back up. And then in California, the statute is that, again, they have to be able to understand the nature of the criminal proceedings and to assist their attorney in their defense. And so if they're not able to do that due to a mental disorder or developmental disability, they can be found incompetent to stand trial. Now, the expert doesn't find them incompetent to stand trial. The expert evaluates them and gives an opinion. As you know, it's my opinion that this person's not competent to stand trial. It's the judge or the jury, depending on the type of case, that actually makes the finding of competence or lack of competence. And again, that gets broken down. So we have a rational and factual understanding, and the ability to assist their attorney in their defense. Now, notice there's no like IQ or cognitive test score standard here. This is kind of vague, right? Rational, factual, assist, and those, it's all open to some degree of interpretation. And so we have to break it down further and think about it from how we understand a person's cognitive abilities. Can they understand and appreciate the charges? Can they understand and appreciate the options for their defense? Can they communicate effectively with and assist their attorney? Can they follow along with courtroom proceedings? Can they appreciate and challenge testimony against them? So to do all of these things, it can be helpful to know, like, well, how intelligent is this person when we give them an IQ test? What's their level of intelligence? What's their reading ability? How well can they pay attention and concentrate? How quickly can they think, in terms of processing speed? How well can they understand what's being said and express what they're thinking verbally? How well can they learn and remember verbal information? And perhaps most importantly, how is their executive functioning? Can they pay attention to multiple things at once? Do they think very simplistically and concretely? Are they able to engage in any kind of abstract thinking, when it comes to understanding their charges or what their potential sentences are, what their potential legal defenses are? Can they engage in problem solving and flexibility in their thinking? Do they get stuck in one line of thinking, even if it's not correct or not helpful for them? And then can they engage in any kind of impulse control or inhibition? And so we can measure these things with neuropsychological tests. And again, there's no hard cutoff, but if scores get down in sort of the lower single digit percentiles, you can start to make the case that this person might have an impairment. And, especially if we're around the first or second percentile with verbal memory or executive functioning, you could say that could potentially impact a person's ability to learn what their attorney's telling them, appreciate the charges against them, aid their attorney, follow along with courtroom proceedings, those kinds of things. Most of the cases of competence to stand trial aren't for neuropsychological reasons. They're for psychiatric reasons, treatable psychiatric reasons. And so competency is sort of set up to look for psychosis, right? Mania with bipolar disorder or psychosis with schizophrenia. And so most of the competency evaluations that happen really are a psychiatrist sitting there trying to determine, is this person doing reality testing? Are they floridly psychotic right now? Do they know where they are? So it's kind of a very gross evaluation, looking for active psychosis that needs to be treated. And those folks, when they are in that state, are sent for competency restoration that usually involves the administration of psychiatric medication to reduce their symptomology, to kind of get them back in their right mind, so to speak, so that they can proceed with their trial. But so many of these clients, especially the public defender's clients, even if they have a psychiatric disorder that causes psychosis, they often have an underlying neurodevelopmental disability. And so the psychiatrist may not pick up on that just sitting there talking to them because they're not doing any testing. But their attorney may find that when they come back from competency restoration, well, yeah, their psychosis is gone, but they still don't seem to understand what I'm telling them. They still can't really remember what we're talking about from one meeting to the next. And so in those cases, when there's really profound intellectual or cognitive impairment, the client may be at a point where they don't really benefit from efforts to restore them. And those sorts of clients, if they're found non-restorable or unrestorable, really end up in a situation where they, are going to need lifelong accommodations and supports. They're essentially a disabled adult. And so the legal system usually does something with them, like send them to Napa State Hospital, depending on what exactly they're charged with. And the sort of flow chart here, so to speak, is, if a court finds them incompetent, like I was just saying, they may go to a state hospital like Patton to go through competency restoration. Now, Patton's forensic expert will find that they're restored to competency, then they're returned to court as competent. And as I was just saying, some attorneys still don't think their clients are competent. And then that's when I get a lot of calls. It's like, hey, my client just came back from Patton. I still think something's wrong with them, and I want to get them tested. And then I was just saying they may end up in a long-term state hospital placement like in Napa if they can't be restored. Sometimes even clients with cognitive impairment and intellectual impairment can be restored. That, of course, is a subjective call, and it's a bit of a gray area. And that's where a lot of my involvement comes in, where we sort of get into arguments about whether or not this person is competent because, the state hospital folks that restore them might say, well, if you really use simple language and you give them a multiple choice option, they can get the questions right about their charges and the plea options and all of this. And while that's all well and good, that's not exactly how the court operates. The court doesn't give them multiple choice options. The court doesn't use simple language. Um, the court's certainly not giving them forced choice options, like is it this or that. So it sort of gets into like how complex are their charges, how complex is their defense that they're going to have to understand, how well can they work with their attorney. Um, so it's not as though someone with an IQ of this score is always incompetent. It really depends on the person's individual characteristics and individual cognitive skills. But there's definitely a gray area where most of my work takes place. Um, okay, any questions about competency to stand trial?
I had a question regarding like the domains. Is there um is there like a cutoff in the like how many domains have to have impairment to be considered, or is this
No,
impairment in
I
one?
mean that's a good question. It's not like there's not a diagnostic um, kind of yeah nosology like that where if you have impairment in these two domains then you're not competent. It's not exactly like that. No, it's a good question. No, it's I mean for better or for worse it's more subjective than that. So the expert has to use the tools of the evaluation, which includes testing, which includes the interactions they had with the patient and what they know from the records and what they know from talking to the family members to come to an opinion. What often happens is a patient is seen by a psychiatrist. Psychiatrist says, "Well, this person, we think they we think they're competent," and sometimes they'll even say, "We think they're malingering because we know they have schizophrenia, but they're like saying they don't know how old they are, and they're saying they don't know where they are, and but we think they're malingering." And they may not have access in that moment to that person's historical records. They just see them right there. And so they get sent back as competent. But then their attorney's like, but look, I have 20 years worth of records showing that this person was developmentally disabled as a child, has been on social security disability, has always had a caregiver, was a disabled adult before they were arrested. And so we kind of have to hash it out and be like, you know, there's all this other evidence that this person they weren't faking, this disability. It's been there their whole life. They just didn't look like what you expected maybe them to look like in the context of what, there's a bias for there's sort of an expectation bias. And when they didn't fit that, then there's a, maybe they did fail some performance validity tests even, but that doesn't necessarily mean they're malingering. Um, and so there's a lot of back and forth around those issues as well. Low performance validity in the context of real genuine disability. That's another area where I'm frequently involved. Any other questions about competence to stand trial?
Um, I think also like how do you keep, I guess, your bias from like if it's a criminal that and you're like, how do you navigate that?
Which bias are you talking about? I
Like
have so many.
let's say like if you're working with the lawyer that is defending the or the process, it would be the prosecutor or the defendant. I always get confused. But like let's say the criminal performed a really bad crime, like a pedophile or a murder or something. Like how do you
How do I personally like put my bias aside?
I guess like when you get contacted by the lawyers to do these assessments, how much information are you given on the case and how much do you choose, I guess, so that it can be an objective evaluation. Does that make sense?
So yeah, I think I get it what you're asking. Does the kind of ick factor of what the person's done affect my ability to evaluate them? And and it takes some effort and some, I think, skill, some learned skill for it not to. I mean, yeah, I know what the person's charged with. And in most of the cases that I see, in most of them, there's actually no real debate over whether or not they did it. It's more about why did they do it, and in terms of any kind of cognitive impairment that contributed to it, or is there anything here that can help explain what happened, or is there anything here that can help educate the court on why this person should not be considered like a normally functioning person, why maybe they don't, if you're going to sentence an average person to life in prison for this, maybe consider not putting this, what turns out to be a developmentally disabled person in prison forever. Maybe they would benefit more from some different, um, outcome. So it's hard at times, but I I think that for that reason, maybe it's not for everyone, but you do have to compartmentalize. Um, and you have to really narrow the scope of what you're doing. And that's part of when I was talking about working with the attorney to come up with a referral question. So that helps, because if my referral question is, does this patient have any cognitive problems related to their history or this brain injury or anything else? And if so, how would that impact their behavior? That's sort of the lane I stick to. I'm not doing a personality evaluation on them. I'm not making moral judgments on them. I'm not even doing a risk assessment on them. I'm just telling their lawyer, I'm helping educate their lawyer what's going on with their client's brain and what that could mean. So sticking to a narrow lane helps a lot. Um, yeah, it's not really fun to read police reports when they're filled with horrible things, but um, that's part of it a lot of the time. Does that answer your question?
Thank you.
Yeah. Hi, Patches, go ahead.
I'm curious, is there ever a point where you are contributing to making referrals to the court for their treatment, or is it more or less just sticking to the explaining what's going on with them, whether they were competent or not, et cetera?
Good question. So let's I'm going to get there with mental health diversion. Okay. Let's just briefly talk about NGI, and then we'll talk more about mental health diversion. Not guilty by reason of insanity. Okay. What that means is when they committed the crime, they had a mental disease or defect. That's the legal terminology. And because of that disease or defect, they were incapable of knowing or understanding the nature and quality of their act, or were incapable of knowing or understanding that their act was morally or legally wrong. Now, can you guys think of an example of what this could look like? Anybody can think of an example?
I think there was the case of the mother who drowned her kids, and then they said that morally she thought she was right. Like she genuinely believed she was saving her children. And so I think if I remember correctly, that was what the defense used in court.
Okay. And yeah, that was the moral one. What were you going to say, Patches?
I was just going to say a person who would commit an offense or a crime like under psychosis or some type of manic episode, possibly.
Yeah, so the moral one I think is trickier than the legal one, maybe, but maybe they often go hand in hand too. Yeah, so if you have a person who's psychotic, um, they may say something like when the police are arresting them, they may say something like, President Trump told me I worked for the federal government, and I was told by the president that I have to kill that person because I'm on a mission, and that person is an alien or is here, trying to assassinate the president, and it's my job to try to kill them. Um, like completely, again, because of mental illness, not doing reality testing, floridly psychotic, delusional. And so that would be an example um, of someone not really understanding in that moment that their act was morally or legally wrong. Now, they may be medicated now and very much back to in reality. They may be able to tell you who they are and where they are. They may not be saying any of that stuff anymore. But yeah, at the time is what matters. And so let's talk a little bit more about what could cause this and what counts and what doesn't count. So the law says that you can't be legally insane only on the basis of personality disorder, adjustment disorder, seizure disorder, or abnormality of personality or character made apparent only by a series of criminal or antisocial acts. You can't only be addiction to or abuse of drugs and alcohol by itself doesn't qualify. So this is a tricky one. So like if you're high on meth and you're psychotic, that by itself does not qualify you for NGI. However, if you're high on meth and you have schizophrenia, then the two things to get like then and like the meth made the schizophrenia worse, that can qualify. So if there's a settled mental disease caused by drugs and alcohol, that so even okay, so this is more about I think alcohol-induced dementia, that sort of thing. But let me come back to like so if you have schizophrenia and then you also happen to be on meth and the meth is making the schizophrenia worse, then that can qualify. Does that make sense? If it's making you even more psychotic. Um, so I actually have a case that I'm working on now where there's arguing back and forth about whether the person had a settled mental disease or not. And a lot of experts have evaluated this person and said, no, 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 this is meth-induced psychosis. It's meth-induced psychosis. It's not schizophrenia. And as long as they're saying it's meth-induced psychosis, then that wouldn't qualify as NGI. But the person's been in jail now for years and they're not on meth and they're still experiencing symptoms of psychosis. So it's looking more and more like this isn't just meth-induced psychosis. It's still there years later. The person's still delusional. It's looking a lot more like some other schizophrenia spectrum disorder, and they just happened to be on meth at the time, which was making it a lot worse. We're going to jump into mental health diversions, and we have plenty of time for questions afterwards. But any quick questions about NGI? Okay, let's talk about mental health diversion. This is a statute designed to divert nonviolent offenders who have a mental health disorder that contributed to their behavior during the criminal offense. By divert, we mean get them out of jail, right? That means they're not just sitting in jail, they actually get out of jail. They must have a diagnosed mental health disorder by a qualified mental health professional. That's you. It must be a DSM-5 TR diagnosis and cannot be, there's three things it can't be though. It can't be antisocial personality disorder, it can't be borderline personality disorder, and it can't be pedophilia. Now, when I've given this talk before, people have asked, why did they single out those three things? And I don't know the answer. I can speculate that they had some expert consultants who told them that maybe the first two were by being personality disorders were not treatable or it's not something that will remit completely like something like other psychiatric illnesses might with their symptoms. And the last one, I wonder if it was really more of a political thing because no one wants to pass a law where their opponent can say, well, they're letting pedophiles out of jail, you know? So, yeah, I'm not sure exactly why they settled on those, but that's what they did. The disorder was a significant factor in the commission of the charged offense, and in the opinion of the qualified mental health expert, the symptoms would respond to treatment. And then in the process of agreeing to do this, the defendant has to waive their right to a speedy trial and agree to comply with treatment. There has to be a determination by the court that the defendant does not pose an unreasonable risk to the danger of public safety. It has to be a non-violent charge. Again, you can't qualify if you've murdered someone or you engage in sex crimes or crimes against children. Again, they're not going to let violent offenders out of jail on this. It's really designed for people that have mental health problems or non-violent crimes who should respond to treatment. And then again, they have to agree to participate in treatment. It can last up to 2 years. So they're checking in with the courts regularly. And then If they complete the treatment, then their charges can be dismissed. So I want to talk about as a neuropsychologist, um, well, this is about mitigation or mental health diversion, but as a neuropsychologist, what conditions should we be looking out for? And remember, it has to be a DSM-5 TR diagnosis, except for those three. So what are we looking out for? Well, we need to think about the lifespan of this client. And the older they are, the more possible causes of neurocognitive decline exist. Some of their problems might be neurodevelopmental, and it might have been present since birth. Some are secondary, resulting from illness, injury, substance abuse, psychiatric disorders, and those tend to emerge in early adulthood. Some, like dementia, emerge later in life. And of course, the effect is cumulative. So no matter the age of the client, all possible past causes should be explored. So you may have a 40-year-old client that looks like a person with schizophrenia, but you may, once you dig into their background, you may also find out that they had a learning disability, or maybe they even have an intellectual disability that was never really fully identified in childhood. And the schizophrenia was just another unfortunate layer on top of, adding to their problems. So when we're looking in their background, we're asking questions about, were they born premature? Were they born early? Were they exposed prenatally to drugs and alcohol? Surprisingly high number of folks in the criminal justice system have fetal alcohol spectrum disorder and are not diagnosed, which has direct implications for their ability to, control their behavior and engage properly with society, and be susceptible to the influence of others and things like that. Of course, there are congenital and genetic conditions. There's intellectual disability, autism spectrum disorders, ADHD, learning disabilities. And then when they get usually into adolescence, we start wondering about substance abuse, the emergence of mental illness like schizophrenia or bipolar disorder in late adolescence, early adulthood. A lot of these folks have traumatic brain injuries. And then, of course, they can get medical problems just like anybody else. They can have HIV, they can have multiple sclerosis. They're going to probably be more likely to have things like neurosyphilis, which comes from untreated tertiary syphilis. A lot of these folks have epilepsy from brain injuries. Many of them have had strokes. Most of them, I don't actually see that many clients with dementia. But there's plenty of folks that have dementia in the justice system as well. Probably earlier on, because if it gets too bad, their lawyers and the judge can see it pretty plainly. But you'd be surprised that you find folks in there that, like, how on earth could nobody be paying attention to this person who's clearly pretty far along. These folks tend to have harder lives where they may be more, their bodies are aged beyond what chronology would suggest, and so their bodies may be aging early. They may have more cerebrovascular compromise. They may have the lifetime effects of alcohol abuse or other substance abuse. Any impairment at that point is likely to be multifactorial. Okay, what questions do you guys have about mental health diversion and just generally what we look for, disorders we might look for the purposes of mitigation, or any other questions from what we've gone over, or questions about my practice? We got about 15 minutes. Ask away. We've got some questions in the chat, right? I can bring those up. Let me stop sharing. Okay.
Patches, did you want to ask your question, or?
I'm going to give other people a chance to answer some of the ones in the chat for people who aren't here and so forth. If it's still lingering, I'll ask.
Okay, so I'll read these. I've got some questions here in the chat. What are some trainings required to become a forensic neuropsychologist? Is it the same process as becoming a neuropsychologist? I don't know if there's one path. I started as the neuropsychologist, and then I've done trainings and work in the forensic setting. I don't really think of myself as a forensic. I call myself a forensic neuropsychologist because that's the type of work that I'm doing, not because that's how I was trained. So I'm kind of a neuropsychologist who works in the forensic setting. Um, as my career goes on and as I do more training and more education and more exposure to what's needed, it's kind of creeping into the forensic neuropsychology world. But it's funny coming to it through neuropsychology first, because just like with any field, there's sort of a lot of dogma that, most people get trained under. And coming in as an outsider, you can look at it with a different perspective. And you're like, well, is that the right way to do this? And, I'm not necessarily accepting everything um, everyone else might be accepting just because that's the way they were taught. So I think that's good in some ways, because I might be curious where somebody else might be dismissive, um, and I might not agree with what the accepted thing is. I might, especially coming as a neuropsychologist, somebody says, well, that doesn't make sense to me because based on the way the brain works, I don't think that that's right. So anyway, I would, of course, I'd say probably easier to start as a neuropsychologist and then get into the forensic world. If I'm sure you could do it the other way. Some people do both. They train at Patton, and really what they're doing is forensic neuropsychology. They're not doing a lot of clinical work. Um, Training in places like that, in jails and in state hospitals, um, is the path most people take. Um, I actually have a postdoctoral fellowship where I am training a postdoc to do neuropsychology, the sort of a hybrid model between clinical and forensic. They do both. There's not that many postdocs like this, but there are more and more. I think there's one at UCLA now, where they have a criminally focused neuropsychology postdoc. Um, so you do have to go looking for it, and a lot of the training you may have to do after your formal training is completed. In terms of specialized certificates, not really. Um, Not that I'm aware of. I mean, continuing education, obviously, consultation. It's great to get board certified in one or the other. Um, there are forensic psychologists that do some neuropsych testing that they feel like is within their scope. And, if they're competent to do that, then more power to them. But I have found that in really complex matters, they would refer to a neuropsychologist rather than try to figure out the neuropsych stuff on their own. Um, so I would say you can't, you probably do have to pick a lane to some extent. And of course, I prefer the lane that I'm in, where I'm a neuropsychologist that happens to do work in the forensic setting. What does the trajectory look like for someone highly interested in becoming a forensic psychologist? Yeah, so as I was saying, you probably end up, or at some point, you're going to probably have to train in a state hospital or a prison. Yeah. And there is a whole, I don't know what division it is, but you can get plugged into the forensic psychology division of APA. You can get board certified as a forensic psychologist. They would have a lot more resources on the specifics of the path to take than I would. What modalities do I currently focus on? That's not really an answerable question. There's no real modality to my approach in neuropsychology. Um, in terms of like a therapeutic orientation, I assume that's what that question means. One of you asked that, feel free to clarify. But I will say that I do an amount of testing that is, I feel, beneficial and necessary, but is also efficient. So I don't give, actually, my forensic batteries probably shorter than most clinical batteries I would typically give. And it's a focused referral question. And I'm trying not to give tests that I don't have to give. And yeah, just being very efficient. Is there anything you would caution a PhD student to assess process within themselves prior to choosing forensic psychology as a career? Um, it is challenging, and I think it's important to have insight into what's motivating you and um, realize it's going to be very difficult. I did not set out to do forensic work. When I was at your stage of my training, that wasn't on my radar at all. I sort of backed into it after postdoc, yeah, at the recommendation of a mentor at the time, and decided to try it out, and then just got more and more into it. And in many ways, it's sort of like a thing. Like once you see it, you can't turn away. That sort of thing. You realize like how much need there is, and how much good you can do in the service of a very broken justice system. So it can be very disheartening to just see how broken things are, and also how broken people are. The clients that we see in these settings are at the lowest points of what is often a very difficult life, where they have not had much chance at anything. And you see a lot of intergenerational problems, whether it's environmental or biological or both, where mental illness just goes right through the family, and they don't have the capacity really to intercede and advocate for their children. And so they fall right into the same trap of poverty and crime and untreated mental illness and substance abuse. And so it can get to be quite heavy, and it can start to feel like, oh my gosh, this is the same story over and over and over again. And so I could see how this work could burn someone out, um, if they, you know, everybody can only put up with so much. At the same time, it can be very rewarding when you can identify a legitimate need a person has, despite what they may have done. That doesn't change the fact that their mom drank their entire pregnancy, and, their brain is malformed because of it. And it won't work like a normal brain should. And that's not really their fault. And so you can identify the problems that they have and potentially get them treatment as opposed to just punishment. And so those kinds of things can be very rewarding. Um, yeah. What other follow-up questions or other questions do you guys have?
How often do you have to get updates on the current laws or any of that? Do you have to update your
How often do I have to be up to date on the law?
yeah.
So thankfully, I work very closely with attorneys, and at this point, they know me well enough and I have relationships with them. So when the law changes, I hear about it through them,
Okay.
because they're the ones that have to deal with the legal aspect of it, right? And so if something, for example, if something changed about the mental health diversion statute, yeah, I would need to know about it. And I probably would want to go to a training on it. But I could also ask them, like, what is the court looking for now? Like, and that actually has happened, where the law came out and then they changed the law a little bit, and then they didn't change the law back. But I I do this work in consultation with the attorneys who retained me. And so um, it's a dialogue process with them. It's an educational process with them, where they're explaining things to me and I'm explaining things to them. And the work is improved through that process. So, my work has improved by incorporating feedback from attorneys that they have given me about my reports. I'll ask them. Um, So the idea that you're going to come in as the expert and you're going to be like, well, I'm the expert and this is what I say, and everybody else is just going to deal with it. I think that's a wrong approach. I think it's better to come in and think of yourself as a consultant and as an educator, and you're working with the attorney. You know a lot more than they do about your domain expertise, your subject matter, but you don't know everything, and you don't know nearly as much about the law as they do. So you ask questions and you try to stay humble while at the same time having confidence in your own knowledge base. and providing opinions that are well-founded. You're not saying anything without being able to defend it. You want to have a reason for saying everything. So um, I've been I enjoyed this work more when it is and done in dialogue with the retaining attorneys. What else?
Was wondering if you could just speak to just maybe like a really memorable case that you've had. Um, why was it memorable? And obviously confidentiality, but things
Yeah,
you can't share. Yeah.
yeah, sure thing. This happened probably about 4 years ago, maybe five now. But there was a case. Most of the clients are men. That is the nature of the justice system. Most of them are minorities, disproportionately. This client was female, and so I saw her at the women's jail, and she was, I don't know, around 30, maybe. Um, and she had been charged with um, some kind of burglary charge because, but what happened was she was homeless and hungry, and she tried to take a sandwich out of a convenience store. And when the clerk tried to stop her, she pulled a knife out and didn't hurt anybody. She just like told him to back off, basically. And so she was arrested for, like armed robbery. And again, the prosecution's job is to like charge the crime, and they're motivated and incentivized to try to get like maximum punishment. And they don't have the facts of like this person's life. They just know this person pulled a knife out and is therefore a threat to public safety. So she had been in jail for years, and she'd been in jail before by the time I saw her. And I tested her, and her IQ was like 60 something. And she had never been properly evaluated. And she had other deficits in, memory and executive functioning, commensurate with that IQ. And um, we went back looking at her records and talked to family. Turns out her mother also had some sort of intellectual disability. She had never held a job. She never lived independently. She had only lived with family or been homeless. And when she was homeless, she would be victimized and, was in danger because she was lower functioning. She was more easily victimized. And she would start using meth and get into trouble. And so the attorney made an effort to use my report to apply for regional center. And she had never had regional center services, and it could be quite challenging for the regional center to accept someone after they're already an adult. Because really, to get regional center, the problem has to be present prior to the age of 18. It's for developmentally disabled people. And so it was a fight, but the attorney used my report and whatever other resources they had to get the regional center to accept her. And because of that, they took her out of jail. After she'd been in jail for years, they took her out of jail. And they put her in like a group home where her medication could be supervised. She could have a place to stay that was safe. She wasn't, out on the streets anymore. And I heard after that she was like incredibly happy and grateful that she had gotten that kind of help. And if you spoke to this person for 5 minutes, it would quickly become obvious. Like, okay, so this person's clearly operating at a level of like cognitive and intellectual immaturity. This is like a child, maybe an older child, but a child in a grown-up's body. And um, so her story had kind of a happy ending, but it's quite shocking how many folks sitting downtown in the county jails are like her, where they just never they fell through the cracks. They never got identified, and they're hopefully their lawyers paying attention to try to get them help. Yeah, so that was a memorable case. That one kind of stood out. Memorable in part because some people paid attention to it, and I got calls afterwards like, I can't believe, you know, you were able to get this person out. We've been trying to get her help for years, that kind of thing. So that was really cool.
Thank you.
Yeah, thanks for asking. What other questions you guys have? I would say that this kind of work dovetails pretty nicely with what you would think Fuller would be into in terms of an interest in justice and aiding the justice system and working with these people that could easily be called the least of these. And so I would hope that over time Fuller would take a stronger interest in this kind of work. I definitely think it's worth pursuing, and there's an incredible need for people who are well trained, both in the neuropsychological aspects, but also in the broader clinical aspects of the work we do, and who are interested in getting further training in the forensic elements that they need to know to do the work. It's pretty important stuff, and it's not going anywhere. It's not a problem that's unfortunately going to disappear tomorrow.
Well, I do want to respect everybody's time, so I want to thank you, Dr. Byrath, for giving some of your time. I know you're very busy and having the time to talk to us, and it was very interesting and very informative, and we appreciate your time.
Thank you again for the invitation. And if any of you guys want to ask further questions or follow up, feel free to reach out.
Do I have permission to send out your contact info, your email?
Yeah, you can give my email out. My private practice email would probably be the best one. I can send it to you so you can forward it.
Okay, sounds good. And we'll be having our last Fuller ANST lecture series on June 9th with Dr. Karen Miller. All right.
Take care, everyone.
Take care.
Thank
Have a
Thank
good
you.
night.
you for being here.
Bye bye.
Bye.